again to show you the CFTR protein, which is thus a chloride channel, and this is the protein at the apical cell membrane when it functions normally and transports iron. And this is again this slide which shows what happens in the normal airway epithelium opposed to the CF airway epithelium with this protein. And you have here the picture of the normal. The CFTR protein is functioning. It transports chloride and sodium, chloride and sodium. And you have a certain amount of airway surface liquid. However, when the CFTR protein is dysfunctional or absent, the chloride is not transported, you have probably an excessive absorption of sodium, and then you end up with a lower layer of airway surface liquid, and then the cilia cannot work normally here. They are entrapped and they cannot work normally, and the mucociliary appearance is not normal. And so you have this defective ion transport, airway surface liquid depletion, delayed mucociliary clearance, and then you will have mucus plugging, obstruction. This will lead to some inflammation in the bronchial wall, and then infection, and then you will have a vicious cycle of infection, inflammation, scarring. Infection with bacteria attracts a lot of polyneutrophils. They will try to kill the bacteria, but by killing the bacteria, they will cause an inflammatory response, and it's a huge inflammatory response, and this is killing the bacteria, but it's also destroying the bronchial wall. And so, cycle after cycle, you end up with destruction of the bronchi, bronchiectasis, and then destruction of the lung parenchyma, which is deserved by these bronchi. And finally, at the end, over years, you end up with end-stage lung disease. Now, what you should know is that CF lung disease, and you know it, is certainly the first cause of morbidity and mortality in CF adults. It is responsible at least for 75% of the hospital admissions. This is an old reference, but it's still quite true. And this is also a very old reference, and it's not completely true, but it's like, it gives some indications. If you have a volume, forced expiratory volume in 1 second, less than 30% of predicted, and your patient ends up hypoxemic and or hypercapnic, which is a sign of respiratory failure, his estimated survival at 2 years is less than 50%. It's not always true, because you have some of the older male patients, adult male patients, who have very bad lung function and very compromised lung function, but who live on like 10, 15, 20 years and then only go on to lung transplantation. So it's not really totally true, but at least this is you should pay attention to these type of patients. They can go on to lung transplantation very quickly or live longer, but you should always have in mind that this can go on to be catastrophic. And then now you know the symptoms and signs of CF lung disease: chronic cough, expectoration, synopsis, dyspnea, exercise intolerance, and sometimes thoracic pain. Clinical examination, when you auscultate the lungs, very frequently it's normal, and only after some time you have crackles in the upper lung zones, and only when it's end stage really you have something like disseminated crackles in the lungs. You have evidently signs of thoracic hyperinflation, cyanosis if it's end stage disease, and clubbing from the beginning. And I just maybe skip these pictures of sputum and clubbing and go on to the topic of bacterial colonizations. You all know these type of slides, and this is drawn from the Cystic Fibrosis Foundation annual data report from 2011, and it shows the different bacteria we see in CF. And let me see, first of all, this is the ages. It's maybe a bit hard to see from behind, but you have here like 2, 2 to 5, 6 to 10, 11, 17, 18, 24. So the cutoff for adults would be here, and then you go on to the older patients. And in green you see Staph aureus, which is one of the predominant bacteria you see in children, and you also have Haemophilus. And in blue you have Pseudomonas aeruginosa, very little chronic colonizations in children, and then it goes up. But evidently, and that in the US at 18 years, about 60–50% of patients are colonized. However, this could be different in your countries. Probably if you have less access to treatment, if the children are sicker, probably this blue curve could be shifted to the left, and you can have more Pseudomonas in children already. But this is the situation in the US and Western Europe. And then you have a lot of these, you have other types of colonization, like with MRSA, the multi-resistant staphylococcus, which is often hospital-acquired, and which you see in the older adults who have already been hospitalized a number of times. But you can also acquire MRSA now in the community, because the overall prevalence of MRSA in the community has risen over time with the fact that everybody uses a lot of antibiotics for everything, not in CF, for every type of patient. And then you have other CF-specific bacteria like Stenotrophus maltophilia and Acromobacter. In general, there's only a low prevalence of these bacteria in CF, even in CF, in older CF patients, and you have the feared Nosocomial cepacia complex, which is a very special and especially resistant bacterium. Today, still, the main interest is for Pseudomonas aeruginosa, because people think that this is the most virulent bacteria. I think it's like, my personal point of view is, I think it's like a bit of a dogma, because I think these other bacteria, when we say they are so friendly, I don't think they are so friendly at all, the Staphylococcus and the Haemophilus. And as Mary pointed out, what we can culture is probably, and what you see on this slide is probably only really the tip of the iceberg, what is really there in the microbiome, in the bronchial tree of these cystic fibrosis patients. But this is what we can culture, and this is how it looks in the US and in Western Europe. Now, we distinguish different types of colonization and infections, and again, it's mainly targeted on Pseudomonas, but it's true for other bacteria also, and for non-tuberculous mycobacteria also. But let's see for Pseudomonas. So we talk of a new infection if the first time the patient has, if the first time we can find this Pseudomonas in the cultures of the patient, and then evidently, and I will come to it back later, we will try to eradicate it. And then if we are successful, we talk of the initial infection successfully eradicated. Then we have patients who have on and off Pseudomonas, and these are this situation is called intermittent colonization. And at some point in time, patients move on to have always Pseudomonas in their sputum or in their swabs, and then we reach a state of chronic colonization. A thing I wanted to show you, and this is for Pseudomonas essentially, is that Pseudomonas, the Pseudomonas we can find in the bronchial tree of the CF patients is not the Pseudomonas you will find in an older patient who has surgery, who is intubated, and who does one bout of Pseudomonas pneumonia. He will have the viral type of Pseudomonas aeruginosa. In cystic fibrosis, the Pseudomonas adapts to the environment of the bronchial tree with all this mucus and so forth, and adapts to, you have a lot of mucus on the surface of the epithelial cells, and it becomes an anaerobic, here it becomes like an anaerobic situation. The Pseudomonas, which has like a flagell, when he colonizes this type of sputum, he loses his flagell, which makes him mobile. He will become immotile, and also he will encapsulate himself into a capsule of alginate and so forth. And then, so you can better understand how we can come to a situation of chronic colonization because you have this big mucus layer which is no longer transported by these poor cilia which cannot work, and you have this encapsulated pseudomonas within this mucus, and evidently, it's logic again, the host defense, neutrophilia, you can see them here, they are just looking at the pseudomonas, but they cannot penetrate into this mucus and kill him, and also there is no vascular structure in this mucus, so if you give antibiotics, intravenous, oral, inhaled, whatever, how will they come there? There is no way to go into this mucus, no real good way. So this is about the adaptation of the pseudomonas to the CF environment. And the last thing I will talk about, and this is not only pseudomonas, but it's all the bacteria. We also have a state of acute pulmonary exacerbation, and I will come back to this a bit later. Now, you know that CF patients have to have a stringent follow-up every 3 months at least, and we do a complete clinical assessment, we do lung function tests, and we do microbiology. And for the microbiology, we prefer to do sputum culture because they are more representative and more useful than laryngeal swabs, and we do it at each outpatient visit. Belgium is a rich country and everybody has easy access to care, so it's probably different from other countries, but we see our patients, at least the older patients, every 6 weeks. In other countries, they are seen every 3 months, but this should probably be the minimum, every 3 months. And at each of these visits, the patient should have a microbiology test. And these tests there should be culture for Pseudomonas, but also other CF-associated bacteria, so the technician has to use specialized media in order not to find a CF-associated bacterium, and you need experienced personnel. In our clinic, we still do it this way. We test antibiotic sensitivity for various colonies we find, and I think a lot of people still do it. There are 2 caveats to this, because when you read the guidelines, you should treat patients, but you should not in the first place take into account antibiotic sensitivity. You mainly take into account antibiotic sensitivity if your course of antibiotic fails, if the patient does not respond to the antibiotics. So probably this is in any case very costly. It's probably not necessary in all instances. And also, again, it's not mathematical. We find Pseudomonas, we have an antibiogram, and we give antibiotics, but as Mary told us, there are lots of anaerobes, there are lots of other bacteria we don't culture, so we should continue to think out of the box. It's not mathematical. We have Pseudomonas, we give antibiotics, the sensitivity, and we give antibiotics. It's not the way it works. It's too simple. CF is more complex than that. Okay, now let's move on to the conventional treatment of the CF lung disease. This has been nicely published by Döring et al. In 2012, but you know all of these. Cystic fibrosis lung disease is treated not only by antibiotics. There are a number of key elements in the treatment. First of all, physiotherapy. Then we have the mucolytics. In patients who are symptomatic, and this is a symptomatic treatment, we can give bronchodilators and inhaled corticosteroids. And then we have antibiotics, inhaled, oral, or IV. Some patients may benefit from anti-inflammatory medications, like azithromycin. In patients who do not evolve very well, this could be added. And in some regions, like in the US, they give very frequently ibuprofen to children. This is not standard in Europe. And then evidently, if the lung is failing, we have oxygen and ventilation. And we have preventive measures such as avoiding cross-infection, avoiding contact with ill people, but we will have a whole talk on this a bit later. Now, in my talk, I will evidently not go into everything because it was treatment of lower airway infection, but I will concentrate 2 minutes on the mucolytics, and I will then give an overview of the antibiotics. Now, for the mucolytics, we have 2 types of medications, DNase or pulmozyme, which is an enzyme which cleaves the DNA when the neutrophils attack the bacteria in the bronchial tree. they die, and they have a lot of DNA which they will liberate, and it's very sticky, and the DNAs will cleave this DNA. The DNAs will cleave the DNA, and thus the mucus will become less sticky. Hypertonic saline, we have nuclear nebulized, I don't know if it's called like this here, but it's hypertonic saline, either 6% or 7%, and it's designed, its destination is to hydrate the airways and also to make the mucus less sticky. To whom DNA should be prescribed? Probably it should be prescribed, if it's possible, to all patients. If they have mild, moderate, or severe lung disease, it is very well tolerated, can be started during a stable phase or during an acute exacerbation. It's a very well tolerated medication, and it should be given for several months at doses of 2.5 milligrams a day. Then we follow up the symptoms, lung function, and the number of acute exacerbations. DNAs, what has been proven is that it reduces the decline in lung function if you continue to give it. If you stop it, your decline in lung function will not continue to work, so you have to go on and give it. But also, one thing that has been shown is that it reduces acute exacerbations. And this is why I put this into the talk on how to treat airway infection, because it has the virtue to reduce the number of acute exacerbations. But no long-lasting effect. If you want the effect of DNAs, you have to continue to give it. Hypertonic saline, it's a bit the same story. This is the study from Elkins, where people did 4 nebulizations of hypertonic saline per day added on their normal treatment, which is probably not a real-life situation. Who does 4 hypertonic saline treatments per day on top of everything else? I don't know. They showed, this is the lung function here, but don't concentrate on this because the lung function changes were minimal. But what they also showed is that there was a longer interval to the next exacerbation. This is exacerbation-free survival in patients who had hypertonic saline versus the patients who were controls. And you can see that also hypertonic saline reduces the number of exacerbations, or at least increases the interval to the next exacerbation. And probably also this hypertonic saline has some influence on bacterial growth. And it's, I didn't put the price of pulmozyme on it because I forgot, but it's a cheaper possibility. Now let's move on to antibiotics. When will we use antibiotics? There are 3 main indications to use antibiotics. First, if we have a new infection with Pseudomonas aeruginosa, then the first thing we want to do is to get rid of it. So eradication is a reason to use antibiotics. Then, when we unfortunately have come into the situation of having a chronic colonization or infection with Pseudomonas aeruginosa, we want to have a maintenance suppressive therapy. And finally, with pulmonary exacerbations, and we will come to this a bit later, we want to treat these patients if it's Pseudomonas or another bacteria. Now, eradication of new Pseudomonas infection. What do we know? And I took this from this standards of care which have just been published. The current belief is that if we leave a new Pseudomonas infection untreated, it will progress to chronic infection. That's quite intuitive. And when you have chronic Pseudomonas infection, then you will go on to have worse lung function, more exacerbation, and a higher mortality. This has been shown. So it is logical to say that we have to have a prompt eradication treatment. Nobody really knows what is prompt. So what is ideal, we don't know. So what is written in the guideline is ideally within 4 weeks of sputum culture. And then we have several ways to eradicate it. In the past time we gave intravenous courses and other types of regimens. There has been a paper in 2006, I think, which showed a Cochrane database review which showed that there is no regimen which is superior to others. So what is frequently used is oral ciprofloxacin and inhaled colimicin. Oral ciprofloxacin either 3 weeks or 3 months, and inhaled polymyxin up to 3 months. Another regimen that works is tobramycin solution for inhalation for 28 days. In any case, whatever you do to eradicate the Pseudomonas aeruginosa, you should be sure that you have eradicated and do follow-up cultures, and then if it's not eradicated, then you can move on to another regimen. Now, at some time point, patients have chronic infections, and then they should have a maintenance therapy in order to have the most limited Pseudomonas chronic infection they can have. And this is the landmark study from Ramsey, which is already very old, but it shows you that in patients who are chronically infected with Pseudomonas, if you do nothing, you give the normal treatment, physiotherapy, and so on, they have this type of evolution. If you give inhaled antibiotics in an on and off mode, on in like here in the gray months and off in the white months, you can have a nice improvement in lung function in the on months, which you will lose in the off months, but you will regain in the on months. I said nice functional evolution. It's not very much, and in my personal opinion, it's not the most important finding of the study. Probably the most important finding is that these patients have less exacerbation, that they feel better. So it's not really for the functional improvement that we do it for limiting the bacterial infection, the inflammation in the bronchi, and the quality of life of these patients. So now the standards of care today, if you have chronic Pseudomonas infection, is long-term inhaled antibiotics, and what is recommended is tobi in an on and off mode. In the US, it's recommended from 6 years onwards. In Europe, it's recommended for all ages included. And there has been a recent paper which has shown that the solution for inhalation is equivalent to the tobramycin dried powder, which is the tobipod haler. An alternative recommendation is inhaled Astreonam, Caiston, if a person doesn't tolerate the tobi or the tobramycin. This drug is not recommended, however, it's widely used for decades now, and so many chronically infected patients have either nebulized or dry powder colistin. For other chronic infections, such as MSSA infection, there are no recommendations. However, in practice, we see it, especially in the adults, if they're heavily infected with MSSA. Some of them also benefit from some chronic suppressive therapy like flucloxacillin or minocycline. This is also the goal is also to minimize symptoms, to minimize the acute exacerbation, and to feel better. However, evidently over time, the patient may become resistant to these oral antibiotics, mainly to the Bactrim. So the new formulations of inhaled antibiotics are now available, at least in the US and Western Europe. I don't know about your countries, but you probably all know them from the internet and from your medical readings. We have the tobramycin solution for inhalation, we have the Astreonam for inhalation, we have the dry powder formulations. However, as you can see, these are very expensive medications. They remain very expensive. And then there are new drugs that are under development, like liposomal formulations, which could have the advantage of being given only once a day or once a week or once every 3 days. And there we have at present an international comparative study between liposomal formulation of amikacin and the tobramycin inhalation solution for inhalation, which is ongoing. And different other antibiotics are also in development, like levofloxacin in dry powder, or vancomycin, either nebulized or in dry powder. So to finish it off, I just want to talk about the concept of pulmonary exacerbation. You know that the patients have chronic cough, chronic expectorations, but at some time points they have flares of relief. They cough more, they cough at night, they have more expectoration. The expectorations are more colored. They lose appetite, and this is what we call a pulmonary exacerbation. and the pulmonary exacerbation is defined by at least 3 new symptoms or signs of this list. So more cough, more expectoration, or a change in the color of the expectoration, darker sputum, fever at least once a week, weight loss or anorexia, and then new findings on the physical examination. But this is not really, in the real world, it's not really what we see. You don't see this, you see this. You see more cough. People who didn't cough at night, they cough at night. They sleep, they didn't sleep anymore, they have more expectoration. So it's mainly in practice we base on our definition of exacerbation on symptoms, reported symptoms. And then, what is the gold standard for treatment if you have a pulmonary exacerbation? The published gold standard is if you have pulmonary exacerbation with Pseudomonas, then you have to give at least a double therapy with a beta-lactamine and an aminosid IV. However, there was a remark. There was a remark from the person from Bucharest earlier. However, there is lack of evidence that we should do it like this, because I will come to this back later. But the gold standard published is beta-lactamine and aminosid. If you also have MSSA, you should add oxacillin, and you can find the relevant antibiotic dosages in this publication. You should also know that CF patients, at least those who have pancreatic insufficiency, for a weight of 60 kilos or 40 kilos, compared to a patient who does not have CF, they have much more lean body mass, and so the volume of distribution of these antibiotics in their body is increased, and they probably also have an increased antibiotic clearance for some antibiotics. All of this has not been completely studied, but in any case, they should have higher antibiotic doses and or shortened intervals of administration, at least these pancreatic insufficient patients. At present, the consensus is that we should give IVs for 10 to 21 days, and the goal is always to return to the baseline clinical situation and lung function, even if this does not always happen. What I want to say is that we do this for now decades, and adults are living longer and longer in our countries, but we now also see also now the price to pay for this treatment, because if you give double therapy with an aminosid over 20 years, you end up having a lot of 40-year-olds who have hearing loss, who have kidney failure before transplantation. This is new now. And you see a lot of toxicity, a lot of allergy. So I understand that in countries where access to treatment or is not so easy, or medications are not so easily available, one wants to give very high dosages of antibiotics, very long courses of antibiotics. But mind you, in the end, okay, if this is necessary for survival, then it should be done. But in the end, the way we did it in Western Europe, you still end up with toxicity and allergy. And also, we should not forget that there's a lack of evidence to do so. It is probable that tomorrow or in the next decade to come, maybe this strategy will change. Maybe we'll come back to one antibiotic over not so prolonged course. It is to be seen if we can go on further like this. Okay, and then just one slide about upper airway infection. Evidently, the bronchial epithelium and the sinus epithelium is the same in everybody, so also in the CF patients. And so bacteria patients harbor in the lung. They also harbor them in the nasopharynx, in the pharynx, and in the trachea. And there are even now there's even now a line of thinking that the first acquisition of, for example, Pseudomonas is through sinus infection, and that we also should monitor the sinus flora. But we will hear more about this in the years to come. And I will skip this because we will have, I will just say a word about it. Evidently, there are some preventive measures: avoid contact with infected persons, have the necessary shots like influenza shots, improve nutrition, and avoid tobacco exposure, be it active or passive. Okay, thank you very much. I'm happy to take your questions.